أوكي. السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم، والحمد لله رب العالمين، والصلاة والسلام على سيد المرسلين سيدنا محمد صلى الله عليه وسلم وعلى آله وصحبه وسلم أجمعين. الحمد لله الذي بفضله تتم النعم. الحمد لله الحنان المنان الذي هو أرحم بعباده من العباد. الحمد لله الذي من علينا بهذه التقنيات لمتابعة المسيرة العلمية والتعليمية. أتمنى من الله أنه جميعكم تستفيدوا من هذه المحاضرات. طبعا بإمكانكم التواصل معي عبر الإيميل، وراح أفتح discussion boards لطرح أسئلتكم. نبدأ اليوم بموضوعنا الآخر حتى نتابع الكرياتينين clearance calculation for doses. ناخد another specific case which is the dialysis of drugs. Okay. Also, the main reference will be the Applied Biopharmaceutics and Pharmacokinetic book. So, the objectives of our class today will be summarized as follows. At the end of this lesson, you as a student should be able to describe dialysis and common dialysis treatments. Okay. Explain the effect of the dialysis process on drug removal from the patient's body. Discuss factors affecting dialyzability of the drugs, as well as calculating drug doses for patients that are on dialysis process. So dialysis, we will explain this process within few slides later. Dialysis is an artificial process in which the accumulation of the drugs or waste metabolites is removed by diffusion from the body into the dialysis fluids. Do you remember the previous lecture content or topic content? We talked about the different 5 stages with renal dysfunctionality. The last one, or before the last one, was in the case of dialysis. And because there is a problem in the kidney functionality, there is a problem in the clearance of the drug outside the body, so there will be an accumulation of the drug metabolites and their wastes inside the systemic circulation. So we should carry out an appropriate process, which is usually an artificial process. It is not natural. To mimic or to simulate the natural process in which the accumulated drug and or toxins or metabolites are removed by diffusion from the body into the dialysis fluids outside the human body. We have 2 common dialysis treatments, which are hemodialysis and peritoneal dialysis. Hemo, blood dialysis. Peritoneal fluid dialysis. Both processes work on the principle that as the uremic blood or fluid, peritoneal fluid, is equilibrated with the dialysis fluid and artificial fluid, okay, there should be an equilibration between the in vivo fluids, which are either the blood in the case of hemodialysis or the peritoneal fluid in the case of peritoneal dialysis. They should be equilibrated with an external dialysis fluid across the dialysis membrane. Dialysis membrane, it is a semi-permeable membrane that is selective. So when there is such an equilibration process, the waste metabolites from the patient's blood or the patient's peritoneal fluid will diffuse into the dialysis fluid, the artificial fluid outside the human body, and subsequently they will be removed or discharged, these metabolites and wastes. Okay, for whom we are carrying the dialysis process, as we have talked previously, mainly for patients with renal dysfunctionality that is in later stages, just before there is a need for kidney transplantation. Now, the dialysate, which is the external fluid, will contain the content of the dialysate artificial external fluid is water, dextrose, electrolytes. These electrolytes including potassium, sodium, chloride, bicarbonate, acetate, calcium, etc., and other elements that are similar in terms of content or identity, as well as in terms of concentration and isotonicity. So they should be similar to the normal body fluids without toxins. So the external fluid does mimic in its content the content of the biological blood fluids and or peritoneal fluids in terms of water, dextrose, and other electrolytes. Okay, except that the external fluid will contain or does contain no any metabolite toxins. So by simple diffusion, the metabolites will be diffused across the semi-permeable membrane from the blood or the peritoneal fluid into the dialysate fluid. Okay, as you can see here, there is a link for a YouTube video, so please try and see it, watch it, copy and paste just this link in your browser, and try to watch the YouTube video, which is not too long, it's around 6 minutes. Okay, we will start initially with hemodialysis. Hemodialysis, where the dialysis or the equilibration will be between the dialysate or dialysis fluid, which is the external fluid containing water and dextrose and other electrolytes, and between the blood. So it's the removal of the soluble substances and water from the blood by diffusion through a semi-permeable membrane. Soluble substances, which soluble substances we want to remove from the patient body? Mainly the toxins and the metabolites and the wastes. So the blood will be removed as a whole from the patient into an extracorporeal circuit. دورة دموية خارج الجسم. Okay, extracorporeal circuit. The blood will be totally removed like a circuit. Then the diffusion and ultrafiltration for the wastes, metabolites, which are soluble substances, will take place in the dialyzer. The dialyzer will contain the dialysis fluid that contains water, dextrose, and other electrolytes similar to those present naturally in the blood. The blood will be cleaned, then the cleaned blood will be returned back to the patient. So to go on further details according to this, as you can see here in these figures, this is the hemodialysis machine. Now the blood will be taken outside, okay, from the patient artery. Okay, when it's taken from the outside the patient artery, it will be going to the dialysis machine, whereas and inside there is present the dialysis fluids. There will be equilibration and there will be diffusion for the waste and metabolites inside the machine outside the blood. Then the blood after have been filtered and cleaned in the dialyzer, it will be going back again, as you see here by the green arrows, into the veins of the patient. Okay, so let us see here. This sketch also is showing us that the initially the blood will be taken outside or removed from the patient body from his arteries. It will be, as you are seeing here with the arrows, circulated in an extracorporeal circuit. This is the extracorporeal circuit. This is the blood pump to enhance the blood flow rate. Then here is the dialyzer, artificial kidney, where is the dialysis fluid inside, and the surrounding is the semi-permeable membrane. Okay. So after passing around the semi-permeable membrane, okay, the blood will be going back again, the clean blood after the wastes had been removed and collected inside the dialysis chamber. So the clean blood will be removed and it will be back again, entering, as you are seeing here is the arrow, into the venous blood for the patient. Back again, look at the dialyzer or dialysis artificial, which is the artificial kidney. As we have said previously, this is the extracorporeal circuit. This is containing the dialysis fluid, which contain water, dextrose, and electrolytes that are in isotonic concentration with that similar in the blood. Look at the dialyzer. We have dialysis inflow, okay, or dialysate inflow, which is the dialysis fluid, and dialysate outflow. The outflow to take the dialysis fluid or dialysate fluid that is containing the waste and metabolite after they have been diffused across the semi-permeable membrane from the blood that is surrounding the dialyzer. So it will be taken outside the wasted dialysate fluid, and it will be replenished inside with a fresh dialysate fluid that is free from toxins and metabolites. Hopefully you have understand the process. It's easy enough. For peritoneal dialysis, the removal of the soluble substances, the waste, the metabolites, and water from the blood by diffusion through the semi-permeable membrane that is intracorporeal. So in this case, the diffusion of the wastes and metabolites from the blood, okay, will be across not the external artificial dialysis machine like artificial kidney. Instead, in our case, or in this case, the semi-permeable membrane is the natural peritoneal membrane inside the body. So it will be an intracorporeal circuit rather extracorporeal circuit. Extracorporeal, in the case of hemodialysis, it's an external blood circuit. Now here is intracorporeal, دورة دموية داخل الجسم, internal. So this is the peritoneal dialysis. As you can see, there is no need for an artificial semi-permeable membrane. So the wastes and water are removed from the blood inside the body using peritoneum as the natural semi-permeable membrane. The wastes and excess of water will be removed from the blood across the peritoneal membrane into a special dialysis solution that is called dialysate that is located inside the abdominal cavity. It will be located, the dialysate, inside the abdominal cavity. Here is the sketch that's showing you the diffusion process for toxins and water or other soluble metabolites from the blood into the dialysis flow. Now let us look, so we have explained and understand the dialysis process, whether kidney dialysis or peritoneal dialysis. Let us go to the factors affecting the dialysability of drugs. Are all toxins or wastes or metabolites dialyzed outside the human body? Here we will answer the question, or in the same manner, or the same ratio, or in the same rate. The physicochemical and pharmacokinetic properties of the drug, it's one of the major factors affecting drug dialysability. Physicochemical, pharmacokinetic properties of the drug. For example, water solubility. Okay. If you remember in the previous slides, I was talking about the water-soluble wastes or the water-soluble metabolites, because you know that the blood, it's an aqueous medium. So, concerning the water solubility, physicochemical characteristic of the drug, if the drug is fat soluble, i.e. water insoluble, these drugs, they are usually not dialyzed. Example, glutathione. Okay, why? It will not be highly soluble inside the blood, and subsequently it will not be easily diffused into the dialysate aqueous solution, which is the composition of dialysis solution is water, electrolytes, and dextrose. So, fat soluble or water insoluble drugs will not be dialyzed. Protein binding. Tightly bound drugs are not also dialyzed. Okay? Example, propranolol, which is 95% bound. Why? Because dialysis is a passive process of diffusion. It's a passive process of diffusion. When they are bound to the protein, they will have very large molecular weight or size, so it will be impossible to undergo simple passive diffusion process. The molecular weight, only molecules with molecular weight of less than 500 daltons, they are easily dialyzed. Example, vancomycin, it's very poorly dialyzed because it has a molecular weight of 1800 daltons. Okay, and finally, drugs with a large volume of distribution. Drugs widely distributed, that does have very large volume of distributed, are dialyzed more slowly because the rate limiting factor is the volume of blood entering the machine. For example, digoxin has a volume of distribution of 250 to around 300 liters. So it has a very slow dialysability. Drugs concentrated in the tissues are usually difficult to be removed by the dialysis. Drugs with large volume of distribution will be usually concentrated inside the tissues or adipose tissues. So back again to summarize the physicochemical pharmacokinetic properties of drugs affecting their dialysability. The drugs with poor water solubility, or they are highly fat soluble, they are not dialyzed. Drugs that are highly protein binded, also they are not dialyzed. Drugs with very high molecular weight above 500 dalton will not be dialyzed. Drugs with a very large volume of distribution will have very slow dialysability compared with drugs with small or volume of distribution. Okay. Other factors affecting drugs dialysability are the characteristics of the dialysis machine itself. For example, the blood flow rate. Sure, higher blood flow give higher clearance rates. Okay, higher dialysability. The dialysate, the composition of the dialysate and the flow rate of the dialysate, which is the dialysis fluid containing the external one, the water, the electrolytes, and dextrose. The dialysis membrane, the permeability characteristics and the surface area available for across which the diffusion process will be carried. The transmembrane pressure, if you are going back just to the figure, just look at the top above the dialyzer artificial machine. In the case of hemodialysis, you will find that there is a pressure monitor on the top of the figure. Okay, I'm sorry, I cannot go just back now. The pressure monitor, this is that you are pressing, you are making filtration, you are making ultrafiltration pressure to increase the speed or rate of dialysability. So the ultrafiltration will increase with increased transmembrane pressure. The duration and the frequency of dialysis, sure, relation is directly correlated. كل ما زادت عدد مرات الدياليسيس as the number of dialysis is more frequent and the duration of the dialysis process is longer, so the dialysability will be enhanced. Okay. So, extra factors affecting the dialysability of the drugs in the dialysis involving uremic patients that are receiving drugs for therapy. The rate at which the given drug is removed will depend on the flow rate of the blood to the dialysis machine, as well as the performance of the dialysis machine and the semi-permeable membrane diffusibility and so on. So first of all, we have talked about the physicochemical and pharmacokinetic factors of the drugs themselves. Next, we have talked about the dialysability factors, characteristics of the dialysis machine. The term dialysis is used to describe the process of drug removal from the dialysis machine. Dialysis, it describes the process of the drug removal from the dialysis machine. Dialysis, it's the clearance term, similar in meaning to the renal clearance, and it describes the volume of the blood completely cleared of a drug in milliliters per minute. So the dialysis, it's the clearance of the drug outside the blood, and it is having the limits of milliliters per minute. Okay. So dialysis, which is similar to the rate of renal clearance in terms of units as milliliters per minute, it's defined by the following equation. Clearance by dialysis, okay, clearance, so it's dialysis, will equal Q multiplied by Ca minus Cv over Ca, where Q, it's the rate of blood flow to the kidney machine. So as you can see by the following equation that the relation or correlation between the dialysis rate of clearance of a drug outside the blood through the dialyzability or hemodialysis is directly correlated to the rate of blood flow. So as the rate of blood flow is increased, the dialysis or milliliters per minute removed of the drug and toxins from the blood will be increased, multiplied by Ca, which is the drug concentration in the arterial blood, the blood that is entering the artificial kidney machine, okay, minus Cv, which is the drug concentration in the venous blood, which is the blood leaving the artificial kidney machine, which is a clean blood and going back inside the human or the patient body. So as there is a difference, the difference in concentration between of the drug between arterial blood and venous blood is high, the difference, as difference is high, so the dialysis rate as milliliter per minute will be higher. The difference will be higher as if the concentration Ca is high, as much as Ca is high, and as much as Cv is high. What is meant by Cv is low? Sorry. Cv is low, the concentration of the drug in the venous blood going back inside the patient body is low, i.e. the blood is more clean going back inside the patient body is cleaner, divided by the drug concentration in the arterial blood just going outside the patient blood, okay? Now, the dialysis, CLD, is sometimes referred to as dialysis clearance. For this reason, it is termed as CLD. Let us take a practice problem to calculate the dialysis. The flow rate of blood to the dialysis machine is 350 milliliters per minute. Okay? This is the Q value in the previous equation. By chemical analysis, the concentrations of drug entering and leaving the machine are 30 and 12 micrograms per milliliter. So entering the machine, 30, it's the concentration in the artery, Ca. 12, it's leaving the machine, it's in the concentration and the going back into the veins, so it's Cv. What is the dialysis clearance? So simple application of the equation. What's the dialysis clearance or the dialysis? The solution of the problem, you are talking about the rate of drug removal will be equaling the to the volume of the blood passing through the machine divided to the concentrations divided by the arterial difference in the blood drug concentrations before and after dialysis. So the rate of drug removal will equal the 350 milliliters per minute, which is the blood flow rate of blood flow into the dialysis machine, multiplied by 30 minus 12 microgram per mil. It will be equaling 6,300 microgram per minute. Now we will divide the arterial blood concentration for the drug, and then we will end of 210 milliliters per minute. It is the dialysis or dialysis clearance. This is as one step calculation of our problem. In practice, the dialysis has to be measured experimentally by determining the arterial blood drug concentration in the arterial blood going just outside the patient arteries and entering the artificial kidney, and Cv, which is the drug concentration in the venous blood, the clean blood going back into the patient outside the dialysis machine, and the Q, which is the rate of blood flow. In dosing of drugs for patients on dialysis, the average plasma drug concentration of patient is given by the following equation. patient that are undergoing the dialysis process, the average plasma drug concentration is given by the following equation, which equal FD naught over the total clearance, total body clearance, plus the dialysis clearance multiplied by tau. F, it represents the fraction of the dose to be absorbed, similar to bioavailability. D naught, initial dose. CLT, it's the total body drug clearance of the patient. And tau, as I have mentioned, the dosing interval. CLD, it's the dialysis clearance or dialysance. And C infinity average, which is the average steady state plasma drug concentration in the patient. This is to calculate the average plasma drug concentration in practice. If the dialysis or dialysis clearance is 30% or more of the total clearance, total body clearance, total body drug clearance out of the patient, adjustments is usually made for the amount of the drug lost in dialysis. So in practice, if the dialysis clearance is 30% of the total body drug clearance of the patient, there is a need for adjustment for the amount of the drug lost in dialysis. The elimination half-life for the drug in the patient off dialysis without dialysis is related to the remaining total body clearance. Okay, the elimination half-life during off dialysis, that there is no dialysis. So if there is no dialysis, the elimination half-life will not be correlated to the dialysis clearance or dialysance. It will be rather correlated to the remaining of the total body clearance and the volume of distribution as shown in the following equation. So T half, elimination half-life, during off dialysis, no dialysis process is carried at that time, will equal 0.693 multiplied by the volume of distribution over the total body clearance. At that time, you will exclude the dialysance or dialysis clearance, because we are off dialysis or the patient is off dialysis. Drugs that are easily dialyzed will have very high dialysis clearance, and the elimination half-life will be shorter, definitely, during the dialysis process, whether hemodialysis or peritoneal dialysis. The drug will be cleared in a faster manner, so the half-life of elimination will be shorter in patients that are on dialysis. So the T half when the patient is on dialysis will be 0.693 multiplied by the volume of the distribution divided by the summation of the total total body drug clearance plus the dialysis or the dialysis clearance. Okay, and K on, which is the first order elimination rate constant of a drug in the patient that he is on dialysis. So on that the patient is undergoing now the dialysis process, so the first order kinetic rate will equal the summation of the two clearances the total drug, the total body drug clearance plus the dialysis clearance divided by the volume of distribution. Okay, so as we both of us agree that the half-life of elimination of the drug will be shorter during dialysis compared with off dialysis. Now, the fraction of the drug that is lost due to elimination and dialysis can be estimated by the following equation. Fraction of drug lost will be equal 1 minus e to the power minus total clearance, total body drug clearance plus dialysis clearance multiplied by T, okay, hours for the dialysis period. So T, it's the hours. Usually it is around 4 hours. It will be mentioned during the problems, divided by the volume of distribution. All this as the power of E, okay? So this equation is based on first order drug elimination, and the substitution of the T will be hours for the dialysis period, which is usually around. Now, as the volume of distribution increases here in the power in the equation, as the volume of distribution increases, the fraction of the drug lost decrease. Just remember, few slides earlier, we have talked about physicochemical factors and pharmacokinetic factors affecting drugs' dialysability. We have said that drugs with larger volume of distribution will have less dialysability. Okay. Examples for these drugs with large volume of distributions: digoxin, which has 250 to 300 liters volume of distribution. Because of its high volume of distribution, it will be sometimes deposited in the deposed tissues or other tissues, so the removal will be slower by systemic circulation and the hemodialysis. So the fraction of the drug lost for the drugs with higher values of volume of distribution will be less the fraction. So fraction of drug lost as an example, during the 4-hour period of phenobarbital and salicylic acid was 0.3 for phenobarbital and 0.5 for salicylic acid respectively. So the fraction removed is 0.5 for salicylic acid, while it's 0.3 for phenobarbital. So as an initial analysis for these conditions or signs, that the dialysis is good for salicylate overdose. The fraction of salicylate or salicylic acid removed by dialysis is relatively larger than the fraction of phenobarbital removed by dialysis. Okay, so it's easily dialyzed salicylic acid because it has a smaller volume of distribution, it has a smaller molecular weight than the phenobarbital, and it has sufficient aqueous solubility, okay, compared with phenobarbital. It will be dialyzed much more easily, so the fraction of the drug lost is higher. So the dialysis is an excellent option or excellent choice in the case of the removal of salicylic acid or salicylate overdose from the patient body. Another example, the fraction of drug lost during the 4-hour period for digoxin and phenytoin. For digoxin, it is 0.07. For phenytoin, it is 0.04 respectively. There is no dialysis for digoxin antitoxication. It's an appropriate process. If there is toxicity with digoxin and overdose, to rely on dialysis process to remove digoxin. As you remember, just a few seconds, as I have told you, that the volume of distribution for digoxin is very high, 250 to 300 liters. So because it has very high volume of distribution, it will be lost in very small quantities during the dialysis process. So digoxin with large volume of distribution, and for phenytoin, we have just mentioned that the phenytoin is highly bounded to plasma proteins, so it will be difficult to be dialyzed. Okay. Now, here is a plot that is demonstrating the hemodialysis, or the effect of hemodialysis on a drug elimination for patients undergoing dialysis process. Here is the time in hours, and here is the log drug concentration. As you can see that during the hemodialysis, which usually around 4 hours, the drug concentration will be decreased rapidly with time. While in the interdialysis period of dialysis, between one dialysis and another dialysis, the drug concentration will remain constant. It will not be easily removed or eliminated outside the body. Then when we are going to another hemodialysis process, it will further decrease more and more. So what's the effect of hemodialysis on drug elimination? During the interdialysis of dialysis period, the patient's total body clearance is very low, and the drug concentration declines very slowly. In this example, the drug has an elimination T-half of 48 hours during the interdialysis period. During the interdialysis of dialysis, the half-life of elimination is 48 hours because the patient total body clearance is very low, and there is no dialysis clearance during interdialysis period. Interdialysis, between dialysis and dialysis, that we are, or the patient is off dialysis. When the patient is placed on the dialysis machine, the drug clearance will be the summation of the total body drug clearance and dialysis clearance will be enhanced, and it will remove the drug more rapidly. For this reason, there is a rapid decline in the drug concentration with time during dialysis. Clinical example: the aminoglycosides antibiotics such as gentamicin, tobramycin, they are primarily eliminated by the renal route. So dosing of these aminoglycosides, gentamicin, tobramycin, is adjusted according to the residual renal function in the patients as estimated by their creatinine clearance. During hemodialysis or peritoneal dialysis, the elimination half-life of these antibiotics, gentamicin, tobramycin, aminoglycosides, they are significantly decreased. After dialysis, the aminoglycosides concentrations are below the therapeutic range because its concentration has been decreased a lot, because it's mainly dialyzed by the eliminated by the renal route. Okay. So, after dialysis, the patient needs to be given another dose of the aminoglycoside antibiotic, gentamicin or tobramycin. Okay. The data in the next table show that the hemodialysis is more efficient in removing the aminoglycosides and antibiotic compared with previous two slides, digoxin and phenytoin. Hemodialysis is not appropriate to remove the intoxication of digoxin and or phenytoin, as shown by smaller half-lives during dialysis period compared to the peritoneal dialysis. Let us take a look at that. So here is the range of aminoglycosides, gentamicin, tobramycin, and kanamycin, amikacin, nitlimycin. Their half-lives, T-half, in hours during dialysis, whether hemodialysis or peritoneal dialysis, and interdialysis. Interdialysis means that they are off dialysis, they are between dialysis. Okay? Look at this. Let us take the first example, which is kanamycin. Kanamycin half-life of elimination while the patient is off dialysis is very long. Okay, 40 to 96 hours. While if the patient is undergoing hemodialysis, it will reduce into very sharp or very significant into 5 hours, the half-life of elimination. While peritoneal is a little bit longer half-life of elimination compared with the hemodialysis. So just as I have mentioned that the half-life of elimination is smaller during the hemodialysis compared with the peritoneal dialysis. The similar is applied for the rest. Look at gentamicin during off dialysis, 21 to 59 hours you have elimination. It has been reduced into 6 to 11 hours during hemodialysis. Definitely peritoneal dialysis will be a little bit higher than the hemodialysis, but it is longer than the T-half during hemodialysis, but it is shorter than the T-half during off dialysis. Okay? Let us have the following practice problem with which we will end our topic for the dialysis of the drug. The practice problem that we have an adult male, he is 73 years old, his body weight is 65 kilograms with diabetes mellitus. Okay, he is placed on hemodialysis. His residual creatinine clearance is less than 5 milliliters per minute. The patient is given tobramycin aminoglycoside antibiotic at dose of 1 milligram per kilogram by an intravenous bolus injection. So when you are talking about 1 milligram per kilogram, his body weight is 65 kilograms, so the total dose will be 65 milligrams. Tobramycin is 90% excreted unchanged in the urine and is less than 10% bound to plasma proteins and has an elimination half-life of approximately 2.2 hours in the normal patients. In patients with normal renal function patients or kidney functionality. In this patient, tobramycin has an elimination half-life of 50 hours. He has declined renal clearance, okay, or during the interdialysis periods, and elimination half-life of 8 hours during hemodialysis. Look at this, how has it been shortened, the half of elimination, half-life of elimination. Now the apparent volume of distribution of tobramycin is 0.33 liter per kilogram. His body weight is 65 kilograms, so we'll multiply 0.33 by 65 to calculate the actual body weight. Calculate the following for these patients: the initial plasma antibiotic concentration after the first dose of tobramycin, the plasma drug concentration just before the start of hemodialysis, 48 hours after the initial topramycin dose, and the plasma drug concentration at the end of 4 hours of hemodialysis, the amount of the drug lost from the body after dialysis, and finally the topramycin dose replenishment dose needed to be given to the patient after hemodialysis to compensate for the drug lost. So first we will start with the initial plasma antibiotic concentration after the first dose. We have been told in the question that the dose is 1 milligram per kilogram. Yes, 1 milligram per kilogram by an intravenous bolus dose. So his body weight is 65 kilogram, so the patient dose will be 65 milligram. His volume of distribution, we have been told that it is 0.33 liters per kilogram. His body weight is 65 kilograms, so the total volume of distribution is 21.45 liters. Okay. So to find the initial plasma antibiotic concentration, the concentration will equal the volume of distribution, the initial dose, patient dose divided by the volume of distribution, which is 65 milligram divided by 21.45 liter. It will equal 3.03 milligrams per liter. This is the initial plasma drug concentration after giving the intravenous bolus dose of 65 milligram. Okay, yet we didn't start yet the hemodialysis process. This is the initial drug concentration. Now the second part of the question was to find the plasma drug concentration just before the start of hemodialysis after 2 days. So the patient was given an intravenous bolus dose 65 milligrams, which resulted in 3.03 milligram per liter initial plasma concentration. After 2 days, we didn't yet start with hemodialysis. What's the concentration? We will depend on the very long half-life of elimination. It's long because the patient has renal function dysfunctionality. Okay. So after 48 hours, the plasma drug concentration declines according to the first order kinetic. You have been taken these equations previously by Dr. May and Dr. Adil. So the concentration will equal the initial drug concentration we have just calculated in the previous step, 3.03 milligram per liter multiplied by e to the power minus 0.693 divided by t half. Okay, it has been mentioned that the half-life of elimination in this patient, because he has renal dysfunctionality, it has an elimination half-life of 50 hours multiplied by 48. What are these 48? The 48 hours after giving the time after giving initial dose. So the result that the drug concentration will be decreased from 3.03 milligram per liter into 1.58 milligram per liter. Then they have been asking us to calculate the plasma drug concentration at the end of 4-hour hemodialysis. Okay, he was given the intravenous bolus dose after and we measure the calculate the initial concentration. So the patient has been given the drug 65 milligrams. Then we measure or determine the concentration initially after giving the initial dose. Then after 2 days, after 2 days or 48 hours, the patient has undergo the hemodialysis process for 4 hours. Now we want to determine the drug concentration after the hemodialysis process. The drug concentration back again, CP will equal the initial drug concentration. It is just before the start of hemodialysis, which is exactly similar to the end after 48 hours from the initial dose administration. Just we have calculated in the previous slide 1.58 milligram per liter multiplied by E to the power minus 0.693 divided by 8. What is 8? T half of elimination during the hemodialysis period. During the hemodialysis or period multiplied by 4 for it's the time between the 1.58 just before dialysis and at the end of the dialysis, 4 hours. And 8, it's the T half during the dialysis. The concentration will be further reduced from 1.58 into 0.547 milligrams per liter. This is the concentration just at the end of hemodialysis process. Then they have asked us the question about the amount of the drug lost from the body after the dialysis. It will equal amount of the drug in the body for dialysis, which is depending on the 1.58 milligram per liter multiplied by the volume of distribution, which is 21.45, minus the amount of the drug in the body after dialysis, 0.547 multiplied by 21. The amount of drug that has been lost is by dialysis 22.16 milligram out of the initial dose, which is 65 milligrams. Then they have been asking us about the topramycin dose needed to be given to the patient after hemodialysis as a replenishment dose. So the recommended ranges of peaks and troughs, peak up and trough down, concentrations of topramycin, these will be taken within the next week, inshallah ta'ala, about the concentrations for topramycin and other gentamicin drugs, aminoglycoside drugs. So the peaks are peak therapeutic concentrations recommended 5 to 10 milligrams per liter, and the trough 0.5 to less than 2 milligrams per liter. Okay. So usually the usual replenishment dose for topramycin after hemodialysis, we are talking from the trough range between 1 to 1.5 milligrams per kilogram. So if a replenishment dose for that patient, his body weight is 65 kilograms, so if we are giving him 1 milligram per kilogram, so 65 milligrams per his body weight, which is 65 kilograms, then the estimated plasma drug concentration is estimated as follows. If you are giving him a replenishment dose of 60 milligrams, so the plasma drug concentration after 65 milligram given as an intravenous bolus injection after hemodialysis will divide 65 by 21.45 and add it to the 0.547, which is the remaining after the hemodialysis. Okay, 0.547, it's the plasma drug concentration after hemodialysis. The end result will be 3.58 milligrams per liter. Okay, So the patient would be given 65 milligrams of tobramycin by an IV bolus injection after completion of hemodialysis to produce a tobramycin plasma concentration of 3.58 milligrams per liter. By this, we have reached to the end of our show, or to the end of our topic for today. I'm available at any time. You can just send me emails and I will open the discussion board, and you can ask me your questions and I will reply during the discussion board time. Thank you, and hopefully you have enjoyed our lecture and understand it. Okay, Assalamu alaikum wa rahmatullahi wa barakatuh.